Good afternoon, everyone, and thank you for joining us. My name is Dr. Steph Kershaw, and I'm a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use, which is located at the University of New Sydney, and I am also the project coordinator for Cracks in the Ice online toolkit. And it's my great pleasure to welcome you to today's webinar. So before we begin, I would like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders past, present and emerging. And I further acknowledge the traditional owners of the country on which you are on and pay respects to their elders past, present and future. So today's presentation is one in a series of webinars which is focused around methamphetamine, and it's running as part of the Australian Government Department of Health funded project Cracks in the Ice. So if you haven't already seen our website, I would encourage you to visit cracksintheice.org.au, and we welcome any comments or questions that you have, so please feel free to get in touch with us at any time. Before I introduce today's speaker, I just wanted to let you all know that as participants, you are in listen-only mode, and that means that we can't see or hear you. However, you will notice that there is a Q&A button on your dashboard, and this is where you can type in questions that you have during the webinar and send them through to us. We'll also have a question and answer section at the end of our webinar. Today's session is being recorded, and the recording as well as the slides will be made available on the Cracks in the Ice website within the next day or so. So it's my great pleasure to introduce today's speaker, Dr. Adam Rubenis. So Dr. Rubenis is a clinical psychologist at Turning Point in Melbourne and is completing a clinical research fellowship at the National Centre for Clinical Research on Emerging Drugs, focusing on treatment delivery and retention strategies for people using methamphetamine. Now, Adam's doctoral research focuses on cognitive predictors of treatment outcomes in people using methamphetamine. So thank you so much for joining us today, Dr. Rubenis. We're extremely lucky to have you with us, and I'm sure this is going to be a really interesting presentation. So I'm now going to hand it all over to you.
All right, thanks for that, Steph. And yeah, perfect pronunciation on my last name as well. Today I'll be talking about the use of technology in psychosocial treatment for methamphetamine use. And Steph did mention I'm a clinical psychologist at Turning Point, but I've also been doing research over the last year or so as a research fellow at NCRED. So I've been really interested in trying to, I guess, get a pretty substantial overlap between the clinical work that I do and research too, so that, you know, the research that I'm looking at is actually useful in a practical way. So today is really, well, I'll skip to the next slide, which gives a bit of an overview. So I'll start just by talking about methamphetamine use in general, and a few statistics on use in the community, issues associated with accessing treatment for a lot of people, and then how technology can kind of fit in with that or facilitate improved access to treatment. And I'll be covering three different modalities. So we've got telehealth, mHealth, so using mobile phones, and then computer-based interventions too. So I'll firstly sort of talk about the evidence behind each of these modalities, and then discuss which what's available for both for clinicians and for people who may have concerns around methamphetamine use and might be seeking support on their own. And yeah, following up from all of that, I will have a bit of a chat about emerging research that's that's coming up in not only these modalities that I'm talking about, but there's a few other kind of technology-mediated interventions that are being developed that are quite interesting. And then finally, I'll follow it up with a Q&A at the end. So to start with, just as an overview of what can be helpful for people, for treatment of people with concerns around methamphetamine use, there's been quite a lot of research done trying to find out what's most effective. As it stands, the strongest evidence that we've got is that cognitive behavioural therapy is quite good. Contingency management can also be quite effective. And there's some sort of promising findings in a whole bunch of other areas. So around medication, I mean, unfortunately, there's no sort of, there's no really well-established medication that can be helpful for methamphetamine withdrawal or ongoing maintenance support. And there's a few other kind of counselling-based treatments or things like exercise and cognitive training that are also being explored. But again, the evidence base there is not quite at that gold standard level yet. So in terms of the things that work right now, contingency management, for those who aren't familiar with it, is basically giving clients, I guess, a reward for either attending treatment or for returning sort of negative urine drug screens or something like that. But there are some, I guess, philosophical objections to using things like contingency management particularly in Australia. And there are also issues around funding and being able to, I guess, get the funds to be able to provide clients with rewards for attending treatment. So where that kind of leaves us is the fact that we know that CBT, cognitive behavioural therapy, counselling, can be really good for methamphetamine, for people with concerns around methamphetamine, but it would be great to be able to find ways to optimise the delivery and the access to this kind of treatment. So I guess that's kind of where I started with when I started looking into this topic. So yeah, I was talking about trying to optimise counselling support, and the reason why that's really important is because at the moment rates of attendance is a little bit patchy. So in some of the research out there, we kind of see that up to close to a third of clients may disengage before they've completed 2 sessions. Sometimes up to 2/3 can disengage before even completing 4 sessions. And clients who've got more complex needs are also less likely to engage. So yeah, these difficulties with attendance and that possible association with poorer outcomes may be partly associated with some of the characteristics of the kind of broader population of individuals that use methamphetamine. Because there are quite a few factors that can make attending appointments and engaging with therapy long term quite difficult. So to start with, there's very high rates of polysubstance use. So most of the studies that I've had a look at show at least 75% of individuals using methamphetamine are also using another substance. But in some studies, it was sort of even in the 90s. So really high rates of polysubstance use. Quite high rates too of lifetime mental health comorbidities. So you can see down the bottom there, rates of social phobia at 25%, panic disorder nearly a third, well, about a third, and psychosis, methamphetamine-associated psychosis and depression, close to 1 in 2 people would have a lifetime diagnosis. And there can also be quite significant use of acute healthcare services. So in one study, there was a finding that 45% of participants had attended the emergency department over the previous year. So, putting this all together, there's a lot of factors that can make it hard to get to treatment, or can make typical treatment not necessarily the most effective option. And on top of that too, there are issues of geographic disparity. So in rural locations as compared to metropolitan regions, we've got higher rates of methamphetamine use. but also more complex patterns of use, so higher rates of intravenous use, higher levels of methamphetamine-associated psychosis. And unfortunately, there's also a lot fewer services available, particularly for those with complex needs in regional areas. So I guess trying to bring all of this together, my thought was there does seem to be a need to make support easier to access because, that we've got geographic issues, but we've also got characteristics for some people that may make it hard just to engage with normal face-to-face treatment. With this in mind, technology has got a lot of potential benefits and may help to address some of these issues. So we kind of know that levels of technology ownership and use are really high. And I think, again, I don't know exactly what the stats are off the top of my head, but I feel like we're close to sort of 90% smartphone ownership in Australia, and a similar amount of people have access to the internet as well. And almost everybody has at least a mobile phone, even if it's not a smartphone. So this, with this climate, I guess it means that there's opportunities for, desktop apps, mobile apps, texting interventions. And yeah, as I mentioned, geographic isolation, complex needs can potentially be better supported, or kind of make services more accessible through the use of technology. But then we've also got the COVID-19 factor, I guess, because obviously the COVID-19 restrictions have resulted in this quite rapid and, in a lot of ways, improvised shift away from traditional face-to-face counselling. But obviously technology gives a lot of flexibility. So even if we're kind of, there's a chance that these COVID-19 restrictions are going to be with us for some time. So technology may be really helpful in its flexibility. So with all of this in mind, I'll run through a bit of the evidence for technology-mediated interventions within the methamphetamine using population specifically. But I'll also describe some of the services that are currently available for clients and clinicians. So to start with, I was going to have a quick chat about telehealth. So the definition of telehealth that I'm using is the delivery of counselling via either telephone or video conferencing software. And within the methamphetamine using population specifically, there were, in the literature review that I turned up, there were 2 papers from one study of individuals who were in aftercare. So they'd already completed an episode of treatment and engaged in telephone counselling as a follow-up after treatment. And what was found was that there were lower rates of self-reported substance use. Telephone counselling was actually more effective for people who were actively using when they started to engage with it. And also that a non-directive counselling style was found to be more effective for those who were resistant to authority. However, there wasn't any change in a biological measure of methamphetamine use, which was the urine drug screen. And this was a little bit of a confusing finding, and it was potentially linked to the fact that the biological measure was only looking at the past week, whereas the self-reported substance use was looking at the past month. So there's some possibility that telephone counselling was helpful for people to, reduce use over a consistent longer period, whereas, results were less predictable over that shorter 1 week period. But this is a lot of speculation because it's based on a single study. Another thing too was that this treatment was done over a 12-week period. So it was a really solid period of getting support over telephone. So because this is just a single study, there were 2 papers that emerged, but because it's a single study, really limited conclusions that can be drawn for the population overall. But I guess bringing together some of that information, some of the characteristics of this population and some of the guidelines for using telehealth in general, there are a few strategies that might be helpful with clients, though I've got to emphasise as well that clinical judgment is probably the most important thing to be thinking about. But I guess because we know that individuals using methamphetamine sometimes may show higher levels of complexity, it's really important to adapt for that complexity if you are using telehealth services. So things like checking the stability of a person's living arrangement, ensuring there are multiple ways to reach the client or re-establish contact if it's lost. More frequently talking about risk and safety, and also awareness of crisis support within a client's local area, because of course you're in one location and the client could be in a very distant, geographically much more distant location. The other thing too that was based off the findings in that study was that the adaptation of counselling style may be important as well. So I mean, I guess this is really saying that, you know, you really need to adapt to the presentation and the needs of your client, which I guess for most clinicians is fairly intuitive. But I guess, you know, there's that really important point that being really directive towards clients who may not be in a position to take on that information could be counterproductive. And I guess another thing too that I haven't really touched on is that for some people that have used methamphetamine over a prolonged period, there can be some cognitive deficits and some difficulties with attention and working memory. And with that in mind, it can also sometimes be helpful to have, you know, brief sessions with quite a clear structure and quite clear things to take away from the session. But as I say, a lot of this stuff is really kind of clinical judgment. You know, you wouldn't kind of apply it in a blanket way. So there are quite a few resources available currently for people who are wishing to access support via telehealth. As I mentioned before, with that rapid sort of shift towards telehealth as a result of COVID-19, the government changed the guidelines slightly around getting private psychology support, and until at least the 31st of March, everyone can access private psychology, subsidised private psychology sessions via telehealth. It's not clear what's going to happen after that date, and it may just revert to the way that it previously was, where people who were in regional or remote regions could get subsidised sessions via telehealth, but in metro areas that wasn't the case. One really good thing as well is just the fact that the number of subsidised sessions that people can access has increased from 10 to 20 over the last year. But the best place to find further information about a potentially suitable psychologist is through the Australian Psychological Society website, where you can search by according to the client's needs and the location of the psychologist as well. But there were also a lot of government-funded drug and alcohol counselling services that made that shift towards telehealth, and a lot of these services continue to offer telehealth support. It seems to be a bit of a case-by-case situation, but there is a lot more openness to telehealth now. So the best place to go to begin that process, that referral process, is the National Alcohol and Other Drug Hotline, which would link you in with your local catchment-based drug and alcohol support. For clients that are looking to engage in telehealth, there's some really good guides on the Turning Point and the Cracks in the Ice websites around telehealth and what to expect. And within Victoria, I'm going to give a plug for Ready to Change, which is part of Turning Point. So Ready to Change offers 6 sessions of counselling over the phone for people with concerns around methamphetamine, but also other substances too. But it is a really good service. And within Victoria as well, there's a specific ICE advice hotline which is available 24/7. So another form of technology that could be really helpful in delivering treatment is mHealth. So mHealth is using mobile phones to deliver treatment, and this can be either via text message or mobile phone app. And in what I was able to find in this population, there are 3 studies of text message based interventions. So in the first study here, which used interactive texting, so this was clients who were texting with a clinician over a couple of weeks, there was some really impressive findings. So these decreases in self-reported use, decreases in intravenous use, also increased length of time since last use, and higher rates of permanently stopping. Though this was in quite a small sample, so it was difficult to draw conclusions from that, impressive though they were. So that second study here was more or less a scaled up version of the first study. It was larger and also included comparisons to other groups. So people, not just the interactive texting, but also automated text messages and self-monitoring text messages. And the findings here were that days of use over the past month reduced by 2 to 4 days at follow-up, but this occurred in all groups, so it didn't matter whether people were getting interactive, automated, or self-monitoring. So I guess that, again, difficult to draw overall conclusions there, but suggests that there was some benefit from potentially just that reflective process that was going on when people were receiving any kind of text message contact or doing self-monitoring. Though, difficult to gauge. And then finally, there was a study on personalised text reminder. So this was a text reminder for medication rather than a reminder to check in around methamphetamine use. But it was interesting that those who got a personalised medication reminder reported fewer days of methamphetamine use in the previous month compared to a generic reminder. So again, it almost, though I've got to stress as well for those who are into their stats, this wasn't statistically significant. So again, I've got to be really careful with interpretations we draw here. But again, it seems like there is some potential benefit here to, whether it's the self-reflection that goes on when receiving an SMS or just feeling kind of connected to some form of treatment that can make a difference. It's not clear. It feels like this is an area that would be really good to explore further because of that, because it feels like there's potential there, but it's just a bit hazy still. The other thing I was going to mention was that for a couple of these studies, it was actually looking at people who weren't engaged in any form of treatment at all. So you can really see the benefit there is, well, there is a great benefit in being able to reach people who otherwise just might not be doing treatment whatsoever. So yeah, findings are inconclusive. Automated and even self-monitoring texts could be as effective as interactive SMS treatment. But I think a few important things about the potential of SMS is that it's a very low resource and low intensity, for clinicians. It's low cost. It may not necessarily take much time, particularly if it's an automated text. as I mentioned before, we've got that possibility to reach people who aren't in treatment and who otherwise may not be getting support. But also because text messaging may reach people in the environment that they live in or the environment where they may be using, it's got that possibility of reaching people sort of in the moment when they're experiencing a high level of craving or another kind of difficult situation. So yeah, really interesting area, and it feels like there could certainly be potential for to be used as an add-on to therapy. I think it's interesting too that we often use, as clinicians, we often use SMS as SMS reminders with clients, but there's no guidance out there really on how to use SMS for as therapy or as an add-on to therapy. So moving on from SMS briefly, so for mobile phone apps, there was one study of a smartphone app that I was able to find for people using methamphetamine, and this was where the app was used in addition to group therapy that everyone received. So people either would have group therapy and the app, or group therapy plus the app and a one-on-one counsellor, or just the group therapy on its own. And this app would prompt people 5 times a day to reflect on their internal and external triggers, levels of cravings, sexual encounters as well. And then the information that they put into the app would be able to be accessed via an online dashboard. So we saw, well, not we saw, but in the study it was observed that there were reductions in self-reported and biologically verified methamphetamine use across all groups. So from this, it seems that, okay, was this methamphetamine use reduction due to the fact that everyone was just in group therapy, which we know is can be an effective treatment for people with substance use concerns. But I guess there were some other issues as well. The fact that there was a small sample size. So, even if there was a small additional effect from the app, we may not have detected it because the numbers were quite small. The numbers of people in the study were quite small. There was also a bit of an issue with the design of the app. So because it was, the information went onto an online dashboard, clients would need to log in using a desktop computer to get to that dashboard, which really takes away from some of the convenience that you get from using an app. And in fact, some of the qualitative feedback that they had about this app was the fact that people tended not to look at that dashboard unless their counsellor prompted them to do it. So while people may have been reflecting in the moment on these different areas, these different triggers and such, there was, there wasn't that kind of overall big picture reflection using the dashboard necessarily because of the design of the app. So yeah, one study, really hard to draw conclusions here. It seems like it could be a really interesting area to be explored further. But yeah, got to be quite conservative in the conclusions we draw here. But I guess despite the fact that the evidence is pretty patchy, there's a fair few resources out there that can support people in this, I guess, using SMS and email, and there's a few apps as well in the picture. So Counselling Online, which is not methamphetamine specific, Counselling Online offers support for people using any kind of substance, and they offer online chat and email support, which is all available online. There's the Australian Drug Foundation's Text the Effects system, where you can text a mobile phone, text a number with the name of a particular substance and then be sent back information about that substance, and I think also how to use more safely. And finally, virtual psychologists. So this is a really interesting, I guess, intervention that takes things a step further and offers full sessions over things like Facebook Messenger or over SMS, potentially over email as well. It's funded by the government to deliver free support for those who are in regional or remote regions, but it is a paid service for people in metro areas. So a few apps in the market as well. So of course, got to mention the Cracks in the Ice app. So this app offers information about methamphetamine use and harm reduction. It's primarily informational, but a really handy thing to have. Then there's also the Scheck app. So this provides information about methamphetamine, but also focuses a bit more on self-monitoring of use, self-monitoring of health concerns related to use, and potential referral to additional supports, which could be more intensive forms of counselling. So I guess it's a bit more sort of treatment focused than Cracks in the Ice. There's also a lot of other apps available through things like the App Store, but the evidence base is often pretty questionable for a lot of these. So yeah, I'll leave apps there for the moment. Yeah, I guess with a lot of these sort of untested apps, it can be a little bit difficult to gauge whether they've been meaningfully evaluated or based on evidence. Finally, desktop computer interventions. So these are more like apps that are optimized to be used on a desktop computer. And there was a couple of studies in this area, though the designs of the studies were very different. So it was really tough to draw strong conclusions here. Again, surprise, surprise. But the first study that I had a look at was looking at people who were based in the community, so they weren't engaged in treatment. And there was an online app that had 3 modules based on motivational interviewing in CBT that people could access, I believe, over a 6-month period or so. And we saw, and so there was one group that was able to access that app, and there was another group that was just a control waitlist group. So there were declines in use for both the intervention and control groups, which was a bit unexpected because we would have expected the intervention group maybe to have higher levels of reduction in use. Though I guess one of the issues with this study was the fact that engagement was quite low. So 37% of people participating didn't even complete a single module. But of those who got on board and did at least one module, there was significant improvements in help seeking and daily functioning. So it feels like, there's some benefit for those people who are engaging. There might still be those motivational issues with people not engaging from the beginning, finding it hard to make that first step. But once people did, there were some potential benefits there. Another important thing about this study was the fact that about 90% of those in the study were completely treatment naive, and they'd not done any kind of treatment in the past. So it was really kind of reaching a group that otherwise may not have got much support. So it feels like there could definitely be some utility there. And the second study was quite different. So it was for people who were already in outpatient treatment, a 5-module app, including relapse prevention, psychoeducation, and self-monitoring. But there was homework feedback given by a trained nurse as well through this program. And it was compared to people who were just doing self-monitoring. Now, there was no difference between these groups on relapse risk or their money spent on drugs at the follow-up period. But in this study, about 2/3 of participants had already been in treatment for over a year. So you kind of think that they already would have made pretty significant changes to their substance use potentially. They'd already be quite familiar with a lot of the content in these modules. So there might have been a bit of a floor effect here where we just didn't, if there was a benefit from this app, I guess the sample that was being looked at may have had characteristics that would make it hard to detect that. Also, the level of substance use at baseline was really very low as well, which again, I guess is to be expected when people have been in fairly intensive treatment for about a year. So yeah, here I may sound a bit like a broken record again, but difficult to draw firm conclusions from these studies. Low engagement and motivation seem to be a problem for those who were in active use. There could be some benefit from these modules for people that did engage. Hard to detect the effectiveness of the intervention in the second study. So, although there have been few studies in the area, there are actually quite a few online resources available. So the Breaking the Ice online app, which was actually the one that was evaluated in that first study that I mentioned on the previous slide, so that community-based study. So that's available for free online. And as you can see, they've done a good job of trying to make it very evidence-based and trying to evaluate its effectiveness. Then there's also quite a few online sort of self-help tools that are perhaps a little bit less interactive. So there's the Your Room online modules, the Drug Aware online methamphetamine self-help tool. And in addition to these, there's also an online app that's been developed to support Aboriginal and Torres Strait Islander individuals who are using methamphetamine called the We Can Do This app, and they're currently continuing, I think they're currently recruiting participants because they're trying to do a good evaluation of the effectiveness of the app. And finally, I'll give Counselling Online another plug here too. It's got an extensive self-help section. This is related to all substances, not just methamphetamine on its own, but really useful website. So I guess in terms of bringing it all together, technology-mediated interventions may be useful in some, quite specific circumstances, based on the research that's out there at the moment. Telehealth could be really useful for those who are in active use. Some forms of SMS support could be helpful. Computer-based interventions may be helpful for reaching those who are not in treatment. But that second point there on the slide, that there's much more research required, that's what I really want to keep emphasising. These findings aren't conclusive or exhaustive or anything like that. There's a lot more to be done in this area. And given how unclear the evidence base is, it's really important to use clinical judgment in figuring out whether an intervention is going to be helpful for a particular client. So considering their characteristics and how a particular intervention could tie in with that client's characteristics or background. So given the lack, I guess the other thing too is the fact that there are a lot of, there's a lot available out there for people to have a look into. But yeah, I guess for individuals who are considering using some of these tools, often they are broadly based on evidence-based constructs. And could certainly, offer a bit of benefit and support, particularly if someone's early on in considering making change. But yeah, it's certainly not a substitute for sort of like engagement with a professional at this point. But yeah, given the lack of clear evidence at the moment, I'll just have a quick chat about some of the studies that are currently running and some ideas that are being developed. So obviously telehealth is an area where there's a lot more research needed, and conveniently enough, Turning Point is running a randomized controlled trial that's looking at telehealth counselling for methamphetamine use specifically. The emails are there if you want more information around it, but please feel free to contact me as well if you'd like more info. I'm actually, you know, full disclosure, I'm going to be a clinician working on this trial, and recruitment's going to be starting in Feb, I believe, and there'll be an online registration system that'll be coming soon as well. There's also the Scheck app, which is still recruiting. So that was the app that I mentioned just before. So in the interests of having an evidence-based app, yeah, they've been recruiting for a while and they're trying to do a really rigorous evaluation of the effectiveness of this app. There's more information that you can find on the Scheck app website or through this email address here. But yeah, sorry, with both of these, feel free, if you'd like further information, my email's at the end of this presentation and you can contact me and I can pass you on further information if you'd like, or get you in contact with people involved in the study more directly. So there's also a bit of technology in development. So although, as I mentioned, there's no really strong evidence for medication for methamphetamine withdrawal or as a maintenance tool, there are apps in development that are going to help to facilitate medication adherence via things like a video, so doing like a video check that a person has taken their medication. And there's also approach bias modification that's sort of in development. So there's been a bit of success using approach bias modification for people with concerns around alcohol. So it's basically trying to change some of these implicit associations that people have with substances. So, you know, typically when someone is dependent on a substance, you know, there's that implicit sense of wanting to approach. But these studies are kind of looking at trying to develop more of an avoidance response to a substance. So there's been some really good stuff done around alcohol. They're recruiting for an alcohol app at the moment, but there's also the possibility of it being adapted into an app for people with methamphetamine concerns. So that's something to kind of keep an eye on for the next couple of years. So that just about covers everything. So I'll just stress again that the info I've provided here, it's not exhaustive. I haven't completed a systematic review, so I'm more than happy for other people to provide feedback or further information. Some of the content in this presentation is also going to be included in a paper that's currently under review. So if you're interested in finding out more about that, or, you know, when it's published, that kind of thing, again, feel free to shoot me an email and then I can let you know when things progress a bit further. But I think that's about it. So thanks everyone for listening, and I'm happy to have a look at the Q&A questions now. And yeah, here's my email.
Hi, Adam. Thank you so much. That was really interesting. And even though you say it's difficult to draw conclusions, it's still good to know what kind of technology-based therapies are out there, or at least in trial. And hopefully as time goes on, their evidence base will develop and we'll be able to provide some more innovative and convenient ways to provide support to people. So there have actually been quite a few questions that come in. The first one is contingency management available to clients in Australia?
So yeah, not an area that I'm so expert in, but my understanding is that it's very uncommon. I think, there even haven't been many research trials done on contingency management in Australia. There's nothing that I know of directly. I feel like there may be a few organisations that are going to be looking more towards low-cost contingency management options, which is kind of like, you attend a session and you might go into a draw to win a prize or something like that. But there's nothing that I'm aware of at the moment.
What are the real barriers to contingency management coming or being more common, I guess, in Australia? Because I understand it's quite common in the US. Is it really around that sort of moral dimension, I guess, about rewarding people for not using drugs?
That's my understanding. So there was a really good qualitative paper, I think, that was talking to clinicians about their thoughts on contingency management, and there were quite strong, I think, like philosophical objections to the idea of rewarding people for attending treatment. Culturally things may be different over in the US. But I think another thing too is the fact that funding for drug and alcohol support is just so scarce in Australia. Anyway, I think it can be harder to make a case where it's kind of like, okay, on top of paying staff, we also need to have these rewards to provide to clients too.
Yeah, well, that's understandable, I guess. You have to prioritise resources. Just in terms of a couple of those apps that you mentioned, someone was wondering if the alcohol app trial you were referring to was the Swipe app?
Yeah, that's it. Yeah.
Okay, perfect. And of the apps, hopefully, I don't know if this will be too hard, but which ones are the self-use apps, I guess? So what apps are appropriate for people who have crystal methamphetamine or methamphetamine use disorder to use themselves?
Was that more for the mobile phone apps?
Yes.
So I really can't speak to the apps that are just in the App Store in general. I think, both of those cracks in the ice, or is it breaking the ice?
Breaking the ice might be the brief intervention one that you mentioned.
Oh yeah, the app is the Cracks in the Ice app and the Scheck app. Both of them are really, really kind of high quality apps. I mean, as I mentioned with Cracks in the Ice, a lot of it is sort of just around, use and harm reduction and just providing information.
Yeah.
Where the Scheck app is a bit more, I guess, active for people who may be a little bit further along the path and actually wanting to monitor and start making change. And as I mentioned, that it's still being evaluated at the moment, so we're not sure exactly of its effectiveness, but at the same time, it's certainly based on evidence-based principles. And it's really sort of heartening to know as well that it's going through a kind of rigorous evaluation process. For the desktop-based apps, Breaking the Ice one is a pretty good one too. Yeah.
Okay, great. And hopefully, the Scheck app will be able to be published their results soon. That'll be interesting to find out. Speaking of the desktop computer apps, are they LLN friendly, which I understand to be language, literacy, and numeracy? It's around the accessibility of them.
Yeah, I'm really not sure, sorry. It's something I could have a bit of a look into.
I guess this kind of leads on to that discussion around, making sort of these interventions accessibly friendly for people with learning difficulties or people from different cultural backgrounds. Has there been much research in the area about, the acceptability of technology-based treatments?
So just in terms of people who may have sort of learning difficulties broadly, or adapting also to cultural differences too?
I guess both. It's quite a new field of study, I guess, technology-based interventions. So have there been any that really looked into learning difficulties or cultural differences. You mentioned the We Can Do This app. I understand that that's for Aboriginal and Torres Strait Islander peoples.
Yeah, and and I was going to mention that as, you know, cultural adaptation. Aside from that, there was, in what I read, there was nothing really clear around adaptations for learning difficulties or cultural adaptation. And I haven't done much reading in the area either. I feel like, unfortunately, at the moment, there's probably more of a reliance on clinicians to have those skills to be able to adapt their clinical work for the needs of clients, rather than there being that many technology-based interventions out there at the moment. But yeah, sorry, I'm not sure.
I don't think you should be sorry. This is just reflective of the innovative edge, I guess, of technology-based treatments. And just because we're into the really tricky questions, I'm going to ask you as well about, obviously, dual diagnosis is quite common with people who have methamphetamine use disorders. Mm-hmm. Is there any sort of technology-based interventions that account for both those mental health and substance use issues?
Yeah, so again, not really that I'm aware of. So I think, I mean, clearly from I guess the statistics around mental health comorbidity for people using methamphetamine, there is like a really great need for a lot more support around that. I would say at the moment, actually, for dual diagnosis, I'm trying to remember the name of the Matilda Centre guidelines that are out there. There's a really good online module.
The comorbidity guidelines?
Yeah, the comorbidity guidelines. So they're not methamphetamine specific, but that's definitely what I would recommend if someone was interested in looking into it further, because that's got, that's very strongly evidence based, and is focused around all substances rather than just methamphetamine. But yeah, I guess in terms of the apps themselves and the technology itself, not that I'm aware of.
Yeah. And are there any additional restrictions for people living in sort of regional and remote areas? I mean, you mentioned that use of drugs is obviously higher in those areas, and access to services is difficult. So, this is an area where technology may be able to forge through where traditional services haven't been able to. What kind of downsides are there for regional and remote areas, if any?
Downside. I think it mostly is around treatment access, but also there can be difficulties with accessing high-speed internet. So even if someone is able to access telehealth appointments, there can be difficulties getting a kind of clear line. So there are some innovations, I believe, where sometimes clients are able to attend a nearby GP clinic or another healthcare centre with a better internet connection to be able to conduct their sessions there. But also, I guess, levels of support being better too, because not only are the levels of support for drug and alcohol use and complex needs sort of diminished, but also around risk and if a client does, if there is a very high risk situation, there can also be those difficulties around accessing medical services too. The nearest hospital could be an hour away, the CAT team could be a couple of hours away. So yeah, I mean, I guess a lot of it kind of rests on the fact that, there's the geographic issues and the fact that there's just not that concentration of services. Often in rural areas as well, incomes can be lower too. It can be, more difficult to pay for services too. So that's why it is awesome that there are these that, for one thing, people are able to access their psychology appointments with a private psychologist via telehealth, and have those potentially bulk billed, but then also that virtual psychologist organisation as well, offering free support for people in regional areas. I hope that kind of answers the question. I feel like I may have gotten a bit off track, but yeah.
No, I think what you're saying is it's really a combination of these innovative technology-based treatments and apps, but as well as possibly also some more investment in the more traditional services, and just having the clinics geographically closer to where people are would be beneficial as well.
Yeah, and I guess there's probably those downsides as well, with the fact that even for some of these online desktop-based apps, if you've got a dodgy internet connection, it makes it hard to get the most out of those. So yeah, a lot of factors.
But hopefully an area where we will see some growth, and we can always hope for better internet, right?
Yeah.
Well, sadly, that's all we have time for today. So thank you so much, Dr. Rubenis, and for all that research that you've been doing into this area. To anyone who has any additional questions, feel free to get in touch via email. You can contact Dr. Rubenis directly, or you can contact us through the Cracks in the Ice website. We will be holding more webinars and putting new resources on the Cracks in the Ice website throughout the year. So I would encourage you all to subscribe to our mailing list to receive future updates. So thank you all again for joining us, and I hope you all have a wonderful day. Thank you, Dr. Rubenis.
Thank you. Thanks.